Hasif. Nampak bronchial ke nampak keruk?
Ha?
Nampak bronchial ke nampak keruk?
Nampak bronchial.
Try keruk jap. Dah bronchial dah.
Dah, bronchial.
Siapa belajar hari ni?
Safura.
Safura,
Seorang?
Hasif.
Najila dengan Una.
Oh, 4 orang ah. Tajuk bronchiasma lagi?
Bronchiolitis,
Okey.
pneumonia. Najila apa?
Najlah keruk.
Keruk.
Oh, okey.
Assalamualaikum.
Waalaikumsalam.
Waalaikumsalam tu.
You guys haven't emailed me your presentation kan?
Not yet.
Tak ada seorang pun email me your presentation. Okay, alright. Are you all here?
Yes.
Yes, Doctor.
Yes.
Okay, alright.
Yes, Doktor.
Please email me your presentations.
Okay, Doktor.
Okay.
Okay.
Okay. Let's begin with Kitab Al-Fatihah. Okay. All right. Let's begin with the first presentation.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and good morning to Dr. Syed and my fellow friends. Today we will be presenting about diseases in respiratory system. So I am Safura Amira binti Shukran, and I will be presenting about bronchial asthma. Okay, asthma, which occurs in adult and pediatric patient, is a chronic airway inflammation characterized by paroxysmal or persistent symptoms such as dyspnea, chest tightness, wheezing, and cough, against a background of chronic persistent inflammation and structural changes associated with variable airflow limitation and airway hyperresponse.
Safura, give me 1 second.
Okay.
Can I see? Most of you didn't put the video on camera. Ramai tak on camera. So whoever has the bandwidth, kalau boleh on camera, because actually I was asked to check because your attendance kena tengok daripada kamera juga takut dia on benda ni and then go pergi jalan-jalan pergi mana, pergi kedai ke apa kan.
Okay.
Alright. Okay, continue.
Alright, it is reversible either spontaneously or with treatment, and it will show more than 20% improvement in PFR or more than 12% improvement in forced expiratory volume in 1 second in response to bronchodilator. Okay, so for the etiology, first is allergens. Allergen exposure and sensitization plays important role in development of allergic asthma. Early sensitization has been associated with increased risk of persistent asthma and bronchial hyperresponsiveness with decreased lung function. Common allergens include house dust mite, cats and dogs dander, cockroaches, fungi, and pollen. While for food and medication allergy, the usual foods implicated are cow's milk, egg, soy, and wheat. But usually, allergic to these foods will resolve in children by 5 years of age. But if the child has allergy to peanuts, fish, and shellfish, this allergy may persist. And food additives such as MSG, monosodium glutamate, and dyes also can trigger AEBA. And for environment, smoking and air pollutant can be common triggers. Most important indoor air pollutant is environmental tobacco smoke, ETS, and passive exposure to it can cause symptoms of asthma at any age of during childhood. So the earlier and the greater the exposure to the tobacco smoke, the higher the likelihood to develop asthma. So smoking during pregnancy can result in impaired lung growth in the fetus. So it will be associated with wheezing in early life. And then air pollutant caused by traffic or indoor. Yes?
You mentioned about smoking.
Yeah.
My question to you is, how about vaping?
Vaping?
I'm
not sure.
Anyone has any idea about vaping? Is it safe for asthmatic patient? Any comment?
does not have any tobacco, right? Any nicotine, right? Ke ada?
Ada nikotin ke tak ada nikotin?
But it also cause addiction.
It also cause apa?
Addiction.
Kenapa? What is the component in tobacco that causes addiction?
Nicotine.
The nicotine.
Nicotine, yeah. So nicotine causes addiction. So they invented vaping actually to reduce smoking, isn't it? It was initially designed as a smoking cessation punya modality. So that is why if used for that purpose, dia kena ada some nicotine lah. Kan? So what's the problem with vape?
Wait.
Vape ni apa? Vape ni apa?
Dia electronic device untuk smoke.
E-cigarette.
What a
E-cigarette.
Dia convert fluid jadi vapor.
Jadi vapor, yes. So dia sama macam kalau in Arab countries, even kat Malaysia pun ada, dia sama macam shisha.
Shisha betul.
So shisha is basically the same thing lah. So they convert water into vapor. So initially this e-cigarette is designed for smoking cessation, kan? Because the idea dia dengan cigarette smoking ni dia ada banyak other chemical irritant, ada banyak problem yang boleh ada plumbum, dia ada lead, dia ada macam-macam chemical component that is bad to your lung. It's carcinogenic and everything. So the idea with vaping is it reduces the risk. Sebab itu actually Public Health England, unlike Malaysia, kita memang ban kita memang ban vaping. Kita ban e-cigarette, but vaping kita allow. Tapi in countries such as England and Italy, Public Health England still they promote vaping. Sebab smoking cigarette in UK is very rampant lah. Tak macam kita kat Malaysia. Kita kat Malaysia we see smoking cigarette as something dirty, as something to be frowned upon. Kan kat Malaysia generally lah. Tapi in countries macam UK, smoking ni is biasa je. Orang pregnant mother pun smoking selamba kat tepi-tepi hospital pun. So the culture is a bit different. So to stop this, they actually promote vaping, e-cigarette and things. So the problem with e-cigarette ni, so they convert whatever water to juice dia tu, vape juice dia, they convert into vapor. Dia still ada some still ada nicotine sebab idea is to reduce the addiction to smoking. Some don't have nicotine. Most will have at least caffeine, tapi dia still produce some amount of lead, still produce some amount of those carcinogenic material, but the number is much lower. Problem dia adalah cigarette biasa, smoke biasa, cigarette smoke biasa, they can control what is the content. Maksudnya walaupun dia ada carcinogen, but the carcinogen are known. The problem with vaping is it is very easy to put other drugs in it. It's so easy to put other inhalational drugs in it. It's so easy to put marijuana in it. So that's the problem. So we cannot control that. So that is why in Malaysia, the decision is to prevent. Because if you allow this, it's so easy. Home concoction, dia boleh tambah macam tu. It's so easy to add on all these recreational drugs, which is dangerous. So that is why in Malaysia we ban this because it's so easy to add on other inhalational drugs. So basically that is the problem. So the complication with those are much more higher. And then there is a study suggesting that with vaping, you introduce new smokers. So it's not just about smoking cessation, it's also about new smokers. Those people who's never smoked, they are happier to try vaping. So this is the problem. So it doesn't serve the purpose. Kalau just untuk smoking cessation, dia okay. Tapi kalau new smoker, and then because dia punya smell daripada vape ni Smell dia kadang ada fruity smell, ada macam-macam smell dia boleh buat di design kan, based on the design dia boleh smell dia okay. Lepas tu pula dia doesn't damage your teeth. Kalau you smoke biasa you punya gigi jadi kuning kan. So with vaping there's no all these aesthetic changes. So the issue is it will look good on people. Despite it has its complication, it may look good on people. So the problem, kita tak nak orang get addicted to vaping and then cause a new problem. So that is the reason why in Malaysia we stop lah. But does it irritate? Does it cause irritation to the lung for asthmatic patient? Yes.
Yes.
Because all of the chemical components in it. So everything that you irritate the lung can cause problem with asthmatic. Okay. Alright, proceed.
Okay. And then for infection, viral respiratory infections such as rhinovirus, respiratory syncytial virus, and human metapneumovirus are the commonest trigger for AEBA. And then cool and too dry weather can also trigger it, as well as exercise. And emotional expressions such as laugh, cry, sadness in the baby can cause AEBA. Pharmacological aspirin and beta blocker can cause bronchospasm and will trigger AEBA, as well as occupational or chemical irritants such as springs can trigger it. Okay, and then for the pathophysiology, the main players in pathophysiology of asthma are IgE antibody, mast cell IgE antibody, dendritic cell, eosinophils, and T helper 2 cell. So when an asthmatic patient inhale allergen, it will trigger a reaction. First, the allergen will be engulfed by the dendritic cell and activates it. Also, the columnar epithelial cell will recognize this and secrete thymic stromal lymphocyte that will activate the dendritic cell. So this activated dendritic cell will activate the T helper cell to differentiate into T helper 2 cell, and also will attract the T helper 2 cell to the lungs. So what will this T helper 2 cell do? The activated T helper 2 cell will promote humoral immunity, thus will promote IgE production by the plasma cell. And then the IgE will then bind to the receptor on the mast cell and create IgE mast cell complex. So this will stimulate mast cell and also will stimulate eosinophil production by the bone marrow. So more eosinophils is produced and will be attracted to the lung. So the inhaled allergen will bind to the mast cell IgE complex, and this will cause mast cell to mainly produce their granules, that is histamine, leukotrienes, and prostaglandin. So all this will stimulate the smooth muscle in the airways to cause bronchoconstriction. And for eosinophil, it carries granules too, such as prostaglandin, leukotrienes, platelet activating factor, and also histamine. So when there is trigger, it will release the granules. So these granules will start to degrade lipids, nucleic acids, and also proteins, and then there will cause two changes. The first one is bronchiole starts to spasm, which will narrow the airway and will increase the mucus secretion in the already narrow airway and narrow it even more, and then will cause symptoms. Okay, so for the symptoms, recurrent episodes of one or more of following: wheeze, cough, shortness of breath, and chest tightness. And then interval symptoms mean symptoms between severe episodes, and the symptoms occur when there is a response to trigger. And recurrent chest infection, failure to thrive, history of atopy such as eczema, dermatitis, allergic rhinitis, allergic conjunctivitis, and family history of atopy. And for the signs, during acute episode, there will be tachypnea, tachycardia, wheeze, generalized expiratory rhonchi, hyperinflated chest, use of accessory muscle, sinuses, and drowsiness. While sign for chronic illness are Harrison-Sulci, hyperinflated chest, and eczema or dry skin. I will show the picture later. So for the investigation, for the bedside is spirometry to know the bronchodilator response, and then arterial blood gas to know any respiratory distress, and identifying the type of respiratory failure, whether it is type 1 or type 2. And then for lab, we can order for full blood count if you suspect pneumonia. and renal profile to see any electrolyte imbalance and effects of medication, because as you all know, salbutamol can cause hypokalemia. And then chest X-ray will show hyperinflated lung. Other tests includes skin prick test to aeroallergen, and also there will be increased exhale nitric oxide because there is inflammation in there. So there is hyperinflation of lung because there is blockage of air passage, and also the air sac become less elastic, so the air is trapped in the lung, cannot be expelled out, so it became hyperinflated.
Safra,
Yes.
do you know the normal PFR?
Normal PFR more than 80%.
That is PFR over FEV1 lah.
Oh,
So you need to, okay, fine. So spirometry itu is a bedside test. We cannot check FEV1 by spirometry. So by spirometry you can only check the peak flow. So you can only check the peak flow with spirometry. So so it's a bedside test. So you need to know the number lah. The other issue is interpreting arterial blood gas. So this is another. So I'm confused. You're year 3 ke year 5?
Year 3.
Year 3.
Year 3. Okay. Mujo. Okay. Fine. So, but you need to have an idea about how to interpret arterial blood gases in the sense that which one you say is type 1 respiratory failure, which one is type 2 respiratory failure. So you need to understand how to differentiate those things. Okay, all right. So how do you know it's hyperinflated? The lung is hyperinflated.
Because tengok dekat dia punya apa ni, mediastinum tu.
Okay, satu mediastinum dia compress. Lagi?
Okay. And then
Anyone else? How to know whether the lung is hyperinflated on chest X-ray?
We calculate the ribs, number of ribs.
Oh yes, okay. So how many ribs is considered as hyperinflated?
7.
If I'm not mistaken, in front 6 to 7, if behind 9.
Yeah, so anything more than 7 in front ribs, and then anything more than 9 for the posterior ribs. So those are signs of, okay, so nak tengok hyperinflation, you tengok few things. Yang pertama, your mediastinum. Mediastinum makan compress, dia kan kecil. So mediastinum. So satu. The second is you tengok dekat ribs, number of ribs. Third is you look at the ribs tu. Kalau you compare here, ada annotation tak sini. So the rib cage here, let me put here. Okay, the rib cage here dia curve. Nampak tak my drawing tu? Tapi rib cage here is more flattened. Nampak tak? Can you see my drawing?
Yes.
So the rib
Yes.
rib cage here is more curved. The rib cage here is more flattened. So flattening of the rib cage. It means is betul ke gambar ni? Macam yang you label as normal ni, yang hyperinflated dia sebenarnya ni. But these two are not, it's not actually good punya comparison lah. Are you sure this is hyperinflated? And this is normal?
Saya ambil dekat radio.
This one doesn't look normal to me. If you count the anterior rib, it doesn't look normal. So anyway, and then you see the mediastinum in the one you label as normal also is a bit smaller here, nampak? Dia punya mediastinum dia very small tapi yang ni dia punya rib cage memang nampak flatten sikit lah. So anyway, what you can do is you compare again. You look at the ribs. So sometimes kita boleh nampak yang ni, I think probably bila di angle ambil daripada bawah kan. So sometimes you nampak dia punya rib dia akan lebih curve. But the idea is how you differentiate between hyperinflation and also normal is the curvature of the ribs lah. So kalau ribs dia more curve macam biasa, it shows that probably it's a normal. Kalau hyperinflation dia more flatten lah. Okay, alright, proceed next.
Okay. Next is asthma positive index. Most wheezing during first 3 years of life is related to viral respiratory infection. So asthma positive index will provide method for predicting likelihood of a later diagnosis of asthma in later years. So if there is more than 3 wheezing episodes per year during first 3 years plus 1 major criteria or 2 minor criteria, we can predict whether this patient has risk for asthma. So the major criteria are eczema and parental asthma, while minor criteria is allergic rhinitis, wheezing apart from cold, and eosinophilia. So this eczema and parental asthma need to be diagnosed by the doctor. So when we ask the family history, we need to ask the parents whether who diagnosed your asthma, who diagnosed your eczema. Okay. So
you know why this is important?
Because
so it need to be medically diagnosed. So doctor diagnose eczema or parental asthma. You know why?
Because we're afraid that the parents diagnose themselves, they have their shortness of breath, so they diagnose themselves as asthma.
True, because we need to make sure that it is a properly diagnosed. It is an actual asthma and actual eczema, because sometimes so many other problems can present almost similar. So these are the things that we need to know lah. Okay, all right.
Okay. And then evaluation of newly diagnosed asthma. So newly diagnosed patient should be properly evaluated to the asthma severity, because we need to make decision on the treatment. So there are 2 categories, intermittent asthma and persistent asthma. For intermittent asthma, the daytime symptoms occurs less than once a week, and the nocturnal symptoms is less than twice a month. There is no exercise-induced symptoms, and brief exacerbations does not affect sleep and activity. While for persistent asthma, there are 3 categories, mild, moderate, and severe. For mild persistent asthma, the daytime symptoms occur more than once a week, and the nocturnal symptoms is twice a month, more than twice a month. The exacerbations affect sleep and activity once a month, and the lung function test is more than 80%, and there is exercise or activity-induced asthma. For moderate and severe, both has daily daytime symptoms, and for moderate, the nocturnal symptoms is more than once a week. The exacerbation affects sleep and activity more than twice a month, and the lung function is between 60 to 80%. And there is exercise or activity-induced asthma. While for severe, there is daily nocturnal symptoms, and exacerbation affects sleep and activity frequently. The lung function test is less than 60%, and there is also exercise or activity-induced asthma. Okay, next are the classification for chronic asthma. We classify patient based on disable if the patient has received corticosteroid treatment before, or the patient has been diagnosed with asthma before. So the classification for chronic asthma is based on daytime symptoms, limitation of activity, nocturnal symptoms, need for reliever or rescue treatment, lung function test, and exacerbation. For it is partly controlled if the child has more than 2 daytime symptoms per week and had any limitation of activities and nocturnal symptoms, as well as needing for reliever more than 2 times per week, and lung function is less than 80%, while exacerbation is 1 or more per year. Okay, for uncontrolled, there are more than 3 features of partially controlled asthma present in any week. Okay, for assessment of severity of acute exacerbation, this table is very important because we need to evaluate the patient once they reach the hospital. Okay, so in mild and moderate, The breathlessness occurs when walking, while in severe, it occurs at rest, and there is apnea in life-threatening. In mild, they will talk in sentence, but moderate in phrases, severe in words, and in life-threatening, they are unable to speak. And for mild AEBA, they may be agitated, but for moderate and severe, they are agitated, and in life-threatening, they will experience drowsy, confused, and coma. For the respiratory rate, mild is normal to mildly increased, and for moderate and severe, they are increased, and there is poor respiratory effort in life-threatening. And usage of accessory muscle is absent in mild AEBA, but present in moderate and severe, and there is paradoxical thoracoabdominal movement in life-threatening. And wheeze is present in mild, moderate, and severe, but in life-threatening, there is silent chest. And for the SpO2, it is more than 95% in mild, but range between 92 to 95% in moderate, and is less than 92% in severe and life-threatening, and there's cyanosis in life-threatening. The pulse rate is normal in mild and increased in moderate and severe, but there is bradycardia in life-threatening AEBA. And for PFR, it is more than 80% in mild and 60 to 80% in moderate and less than 60% in severe. And in life-threatening, we are unable to perform PFR. Okay, so next is the management. The drug therapy consists of two components, for relieving the respiratory symptoms and also reducing the airway inflammation. For the reliever therapy, it is used to alleviate the respiratory symptoms, and we can use short-acting beta-2 agonist SABA, such as salbutamol, for this purpose. And then for the preventive therapy, it is anti-inflammatory treatment for the prevention of the symptoms, and we can use inhaled corticosteroid as well as leukotriene receptor antagonists. Okay, based on CPG, for children from 0 to 6 years old, we should be given with metered dose inhaler with spacer that has face mask. While for children more than 6 years old, we can give either metered dose inhaler and spacer with face mask or mouthpiece, but usually face mask is for infant and babies, and mouthpiece is for all the kids and teens. Okay, we can also use dry powder inhaler, and I will show the picture after this. Okay, so the flow of management is, first we need to assess the asthma severity based on the table I showed before, whether it is newly diagnosed or controlled or uncontrolled, and then we can choose the preventive treatment, whether we can give inhaled corticosteroid or leukotriene receptor antagonist based on the algorithm in the next slide. And then after 4 to 8 weeks, we assess the asthma control, and then we will follow the stepwise medication to there is a reduction in the therapy based on the algorithm, and then we will monitor the asthma control frequently. Okay, this is the algorithm for management of acute exacerbation of asthma. Okay, salbutamol is the first line treatment for acute asthma and bronchodilators of choice. So it should be administered rapidly after quick history, physical examination, and vital examination. So we will load the spacer with one puff at a time and give each puff separately. Okay, so parenteral or subcutaneous route of salbutamol should be given with in children with severe or life-threatening exacerbation. Okay, then we can give systemic corticosteroid. Systemic corticosteroid are essential treatment of AEBA to speed up the recovery and should be given early. Okay, so for my asthma, we can give oral prednisolone, while parenteral route, we give hydrocortisone or methylprednisolone, and it is indicated in children who cannot tolerate orally or is vomiting, and also in severe or life-threatening acute exacerbation. Okay, if the patient, if the children with severe or life-threatening asthma and the SpO2 is less than 95%, we should give oxygen. So we give oxygen and SABA via nasal prong or face mask oxygen to relieve the hypoxia. Okay, Other therapies are ipratropium bromide. Ipratropium bromide may be added in nebulized SABA in patient with moderate to severe AEBA or those who doesn't respond to SABA alone. And aminophylline, parenteral aminophylline should be can be considered in high dependent unit or PICU setting for children with severe or life-threatening asthma and those who are unresponsive to maximal dose of bronchodilator and steroid. And then for IV magnesium sulfate should be considered as adjunct treatment in severe or life-threatening exacerbation unresponsive to the initial standard treatment. And it is safe and beneficial for severe acute asthma. Okay, for long-term management, long-term asthma management. Okay, for intermittent asthma, we can give intermittent salbutamol. And then mild persistent asthma, we can give low dose inhaled corticosteroid or leukotriene receptor antagonist. And then moderate persistent asthma, we give moderate dose of inhaled corticosteroid. For severe persistent asthma, we give moderate dose of inhaled corticosteroid combination therapy. Combination therapy is we give inhaled corticosteroid and long-acting beta-2 agonist. Adding long-acting beta-2 agonist to inhaled corticosteroid is more beneficial than doubling the dose of inhaled corticosteroid. And then for severe persistent asthma, we give moderate dose of inhaled corticosteroid combination therapy and add leukotriene receptor antagonist or high dose of inhaled corticosteroid combination therapy. Then add theophylline or alternate day oral corticosteroid. Okay, so these are the devices. Spacer with mask. So we need
back.
Okay.
Let me see. Step 4, step 1 is okay, fine. Step 2 is low dose ICS or LRA. Okay, fine. Step 3 is what is moderate ICS. Okay. There's a problem here. Where did you get this?
From the CPG.
CPG. Okay.
Yes.
You know what's the problem?
I don't know.
This is an old guideline. So yes, CPG is important. Is good. It's important. Yes, but you need to know that you need to look at the latest guideline. So the easiest for you to look is actually on our PITS protocol. So our PITS protocol pun, you don't look at, jangan tengok pada PITS protocol yang lama. Look at the 2019 punya PITS protocol. So in pediatric protocol, they've included the latest changes. The algorithm for management of acute exacerbation is almost the same, but the algorithm for long-term management is a bit different. So if you semua guideline for asthma ni, where do we get? Dapat daripada mana? Biasanya, what is the main reference point for asthma management?
Kalau guide PITS protocol.
Oh, okay, fine. You pernah dengar GINA guideline tak?
Oh, GINA.
So GINA, GINA. So GINA is Global Initiative for Asthma. So this is for adult and also for children. So GINA guideline, dia akan keluarkan new guideline every few years. I think 2018, the end of 2018, they produced a new guideline, the latest update to their new guideline. So and then that is why our pediatric protocol, I think version 4, our pediatric protocol yang released in 2019 have updated the algorithm for long-term management based on the latest GINA guideline. Actually GINA baru keluar satu lagi new guideline yang reflect COVID issue recently. I haven't seen that protocol yet lah. But I think they doesn't change much in terms of the management. For example, they suggest adding kalau you tengok dekat our PITS protocol by step so step 1 sama, step 2 sama. No. Okay, so kalau you tengok dekat new punya guideline, even for step 1, they can consider low dose inhaled corticosteroid, even for step 1. So step 1, you use the reliever medication with SABA, but you can also consider giving low dose ICS for probably shorter duration. And then step 2, you add on obviously low dose ICS, inhaled corticosteroid, or you can add on leukotriene receptor antagonist, or you can add some low dose theophylline as well. For step 3, you kena naik kepada medium dose ICS, or you can add on LABA as well, low dose ICS with LABA, and also low dose ICS plus leukotriene receptor antagonist. And then step 4, medium to high dose ICS and LABA. LABA macam formoterol dan sebagainya. And then also in step 4, you can use medium or high dose ICS plus leukotriene inhibitor antagonist. So there are some changes yang we should have actually looked at lah, how to manage asthma ni. And actually I think in the next few, probably next year pun akan ada few more changes as well, because they are going towards inhale steroid nebulization apa semua, which I think is quite new lah, steroid nebulization. Okay, fine. So yang ni jangan pakai.
Okay. So betul. Okay. Next is the devices. Okay, spacer with mask, spacer with mouthpiece, and this is the dry powder inhaler. Then this is the eczemated skin and Harrison.
Wait, back. Why do you think in children dia tak boleh pakai direct inhaler tu?
Sebab kita nak make sure.
I'm asthmatic. I have my own inhaler which I bring everywhere. So why children tak boleh pakai direct inhaler macam ni?
Because we are afraid that the gas, dia can control the gas. Kita nak direct gas tu masuk dalam mulut terus. Sebab we are afraid gas tu akan keluar. Kita nak make sure.
Anyone else has any other suggestion? Why in children we need the spacer device?
If I'm not mistaken, it is because the children cannot count until 10.
Are you sure children cannot count until 10? 3 years old they can't until 10 kan?
Oh. I'm sorry, I'm not sure.
Okay, let me show you. Nampak tak my video ni? Okay, fine. Let's see. So this is an inhaler. This is one of warna purple ni. This is combined medication. Dia ada LABA dan dia ada inhaled corticosteroid. Foster brand dia. The brand is Foster, nampak tak? So Foster, dia ada, this one has beclometasone and formoterol. So dia ada inhaled corticosteroid and also, so for example bila you tekan, dia keluar. Nampak asap tu?
Doktor, kena buka video doktor macam mana?
Ada video ni? Tak nampak ke video? Oh, okay, I know why. I know.
Kena present.
Wait, because I put spotlight video. Fine. Okay, sekarang nampak tak?
Okay.
Okay, so wait, let me see. So this is my inhaler, warna purple. Warna purple ni is combined punya. Dia ada LABA, formoterol, and also ada ICS, which is beclometasone dalam ni. So if you can see here, bila you tekan, dia keluar asap, nampak?
Yes.
Kan? So untuk for proper use, so benda ni dia adalah apa tahu, if you goncang you boleh rasa dia punya ubat dalam tu. So it's suspended, the drug is suspended dalam this bottle. Sebab tu kita kena shake kan. Lepas tu dia ada teknik, the technique is a bit steep. Macam mana dia steep maksudnya, you kena goncang. And then sebelum you sedut, dia kena prime dulu. So you kena sedut slow sikit. lepas tu tekan and then disedut kuat-kuat. Macam tu. Contohnya kan, macam sedut sikit. Macam tu. Sebab ni dia kena prime sikit, sedut sikit, lepas tu tekan yang sedut kuat-kuat. Baru you can make sure all the drug goes inside your lung. Sebab kalau tak, dia akan stuck dekat your oral, stuck in your airway. Dia tak masuk dalam you punya ni. And then with steroid pula, dia boleh cause fungal infection dan sebagainya. So that is why it has quite a steep technique untuk kita guna. Quite a steep technique untuk kita guna. Even adults pun sometimes, if you go to many countries macam UK dan sebagainya, even for adults, they still suggest kita guna spacer. Back Sapura, gambar ni. Thank you dah. Habis dah. So spacer dia ada spacer with mask, ada spacer with mouthpiece. So spacer with mask ni, dia punya teknik pun lebih senang. Maknanya you just letak dekat, benda ni pernah masuk exam tau. Usage of spacer ni pernah masuk exam. Pernah masuk OSCE. Kita letak satu aero chamber kat situ. And then kita suruh you identify what is this, how to use this, what advice you want to give to mother dan sebagainya. So benda ni pernah masuk exam, especially in your time yang kita tak dapat buat banyak clinical exam. You certainly need to expect we do more of this sort of testing kan. So in children yang less than 6 years old, bila dia guna face mask tu, cara dia guna senang. So kita letak kat muka dia, kita tekan and then dia breathe macam biasa dekat mask tu. Dia depend on device juga. Kalau contohnya kalau dia beli yang Philips Opti Chamber, Philips Respironic Opti Chamber, dia breathe 5 kali pun cukup. Tapi kalau dia guna brand Aero Chamber, dia kena breathe 10 kali. Breathe 10 kali dengan that spacer tu. Mouthpiece pula dia ada teknik yang lain. Sama ada dia breathe direct dekat mouth bila tekan dan dia breathe, ataupun dia tekan, dia breathe macam biasa kat mulut dia 5 times macam tu. So dia depends. Okay, so yang ni untuk spacer. Dan spacer ni, kenapa spacer ni? Sebab dia akan mixkan dia punya drug tu, dan dekat wall of the spacer ni dia ada satu komponen, ada satu covering yang prevent the drugs from melekat dekat dia punya wall of the spacer tu. Okay, so in children generally kita tak boleh guna direct inhaler yang ni, metered dose inhaler ni. ACUHaler, so dry powder inhaler you tak mention. Dry powder inhaler ni ada banyak jenis. Apa jenis, and anyone knows jenis-jenis dry powder inhaler yang lain. So ACUHaler ni yang bentuk bulat macam ni. Ini fluticasone lah ni. Yang color purple ni. Fluticasone color orange. What is this? Not sure ni. So, yang ni ACUHaler. Anyone has any idea of other dry powder inhaler? So, dia ada banyak jenis kan. Satu ACUHaler bulat. Dia ada yang rupa lebih kurang sama macam ni. Nampak tak my video? Dia ada sama rupa lebih kurang macam ni. Nama dia EasyHaler. So, EasyHaler ada beclometasone EasyHaler. Dengan salbutamol EasyHaler. Sama, bila dia tekan, dia klik. So dry powder ni apa jadi, bila dia tekan, bila dia pusing macam ni, bila tekan dia keluar gas kan. Tapi kalau dry powder inhaler ni, bila dia tekan, dia pecahkan satu blister. Dia ada satu macam bekas blister macam pil-pil tu. Dia pecahkan benda tu and then dia keluar this small dry powder. This dry powder is very small. Dia very very small size. It's quite easy to get into the lungs pun. Kan? So satu ACUHaler, second yang rupa lebih kurang macam ni, nama dia EasyHaler. You tekan, dia klik and then dia sedut. Yang ketiga kalau you tengok dia rupa macam roket. Nama dia TurboHaler. TurboHaler. So itulah generally jenis-jenis dry powder inhaler yang ada. Dry powder inhaler in terms of technique is a bit easier daripada MDI yang biasa. Dry powder inhaler is a bit easier daripada MDI. So sometimes children more than 10 years, kita boleh guna dry powder inhaler. Okay, again, these things can come out in your exam. Especially, you all dah start ada apa nama yang ni, man or ski, kan? So man or ski kita boleh je. Okay, kita letak device satu, kita letak this chamber, advice. Kita letak seorang berlakon as the mother, and then how would you advise the mother how to use this inhaler with spacer? So this is sort of questions yang definitely easy for us to make lah. So kena tahulah cara nak guna macam mana. You all akan ada masuk kuliah tak nanti? Don't remember lah, year 3.
Masuk kuliah maksudnya?
You all akan ada datang kat kuliah tak?
Tak tahu lah sebab sekarang ni pun tak definite jawapan lagi.
Fine. Tak apa. Just remind me, kita kena buat satu session lah untuk teach macam mana cara nak guna all these devices. So we can arrange another time where I can bring the devices and then I'll show you lah. Sama ada we do online or kalau you all dah balik nanti kita boleh buat ni. So just remind me before your exam, we do one session to know these devices. Okay. Alright. Okay, proceed.
Right. Okay. This is the asthmatic skin and Harrison sulci. Harrison sulci, there is horizontal groove along the lower border of the thorax, corresponding to the insertion of the diaphragm.
What is okay? Where is the insertion of the diaphragm?
Okay. Ke bawah ni tu.
So this is one question that I always see students get confused. For example, memanglah kat bawah tu kan you ada nampak draw, that's okay, fine. So I remembered few days back, I think your year 5 group, I asked them, what is Harrison sulcus? Some of them answered subcostal. Harrison sulcus is at the subcostal region. Do you agree with that? Is it subcostal?
No, yes, yes.
No, yes. So no ke yes? Jawapan dia no lah. So Harrison sulcus is at the insertion of the diaphragm, which is at the level of the 10th rib, rib ke-10. Kenapa rib ke-10? Because your diaphragm inserts at the level of the 10th rib. Kan? Kenapa dia jadi Harrison sulcus? Sebab this child has chronic asthma. Bila chronic asthma, dia selalu dapat respiratory distress. You know, diaphragm is your main respiratory muscle. Your main respiratory muscle is your diaphragm. Diaphragm, abdominal wall, intrathoracic, intervertebral muscle. So, but your main respiratory muscle is your diaphragm. So, bila selalu respiratory distress, your diaphragm ni dia bekerja keras lah. So bila dia bekerja keras, dia selalu pull on your chest. Dan where dia pull at dia punya insertion. Dia punya insertion is at the level of the 10th rib. So sebab itu dia akan jadi indentation dekat chest tu at the level of the 10th rib. So yang ni yang menyebabkan Harrison sulcus. So apa lagi chest deformity yang ada selain daripada Harrison sulcus? This is not Harrison sulcus . Ni apa ni? Gambar bawah ni. Gambar bawah tu gambar apa ni? What are you trying to show?
Saya tunjuk Harrison sulcus.
Mana Harrison sulcus dalam gambar bawah ni?
Dua-dua. Dia
gambar bawah ni which one Harrison sulcus ya?
Dekat itulah dekat bawah thorax ni. Kat situ.
Okay, that is totally wrong lah. Totally 100% is wrong lah. That is definitely not your Harrison sulcus. That is your subcostal region. Macam mana nak buat annotation lah? Okay. So this is your subcostal margin. This is subcostal margin. So recession bawah ni is subcostal recession. Tak ada hereditary sulcus. 10th rib dekat this area. So tak ada. This one is not the picture of hereditary sulcus. What is this? You nampak ni? Nampak bulat-bulat ni? Nampak bulat-bulat ni? Nampak bulat-bulat ni? Semua ni. Nampak tak? Nampak tak my drawing? Okay, let me delete.
Nampak.
Let me delete again. Okay, this one. Sekali lagi This one. Nampak tak? Bulat bintik-bintik ni. What is that?
Okay.
What is that?
Subcostal recesses.
Bukan. Tu compare dengan yang rib kat atas, gambar atas tu. Ada tak nampak benjol-benjol bulat-bulat tu? Those nodules, macam nodules tu. Okay, this is another picture that always come in your exam.
Yang rosary tu ke doktor?
Oh yes, this is rickety rosary. Or rachitic, the spelling proper is rachitic rosary lah. R-A-C-H-I-T-I-C, rachitic rosary. R-O-S-A-R-Y. Ataupun orang panggil juga rickety rosary lah. Because this is a complication of rickets. This is another picture that always come in your exam. This has nothing to do with asthma.
Yes. Okay, doktor. Saya ambil kat internet.
Internet is not always right. So this is rachitic rosary. Dia selalu masuk exam. You selalu, tapi setiap kali masuk exam mungkin 30% jawab betul kot. So this is rachitic rosary. It's very interesting punya picture. Senang masuk exam. Gambar dia menarik. Okay. Apa lagi chest deformity yang boleh ada pada ada gambar lain tak untuk chest deformity ni?
Ada dah.
Okay, what are the chest deformity yang you can see in chronic asthma?
Hyperinflated chest.
Okay, hyperinflated, yes. What can you see in hyperinflated chest?
Dia ke depan ada tu.
Yes.
Ke depan.
Nama dia barrel chest.
Barrel chest.
Barrel chest or basically barrel chest means increased AP diameter. Increased AP diameter. So barrel chest. So it can happen in children as well. Lain. Apa lagi?
Pectus carinatum.
Pectus deformity. So both pectus carinatum and pectus excavatum boleh jadi in asthmatic. So both can happen in asthmatic children. So pectus deformity is another deformity that you can see in children with asthma. Ada few changes lain juga. You know asthma is associated with allergic rhinitis. Kalau allergic rhinitis, what can you see?
Ada hypertrophic turbinates.
Okay, itu kalau you pergi teropong dia punya nose lah.
Hidung.
Okay, fine. Husna Hayati, you're trying to show something.
How about salute sign?
Salute sign, yes. What is salute sign? Nak tegak apa salute sign?
Dia ada macam tanda dekat atas ni sebab dia selalu buat macam ni.
Dia selalu buat macam ni kan. Selalu buat macam tu, selalu buat macam ni. So dia ada line kat hidung dia. If you see me, you can see salute sign. So salute sign is a sign of allergic rhinitis. So these are things that you need to look for. Kan? Okay, alright. Proceed.
Dah habis doktor. Thank you.
Habis dah? Okay. Fine. Any question to the presenter? Okay, let me say something about asthma. Okay. There are several diseases in children that you need to know in great detail. You need to know about asthma in great detail. You need to know about thalassemia in great detail. you need to know about dengue in great detail and nephrotic syndrome in AGN. But asthma, the thing is, before PKP lah, before MCO, asthma and its phenotype, asthma phenotype ni macam acute bronchiolitis, viral, post-viral wheeze, episodic wheeze. Asthma satu disease, dia punya phenotype dia yang lain, jenis-jenis lain ni, chronic lung disease, hyperactive airway disease, episodic wheeze, multi-trigger wheeze, post-viral wheeze, acute bronchiolitis, semua simptom-simptom yang causing wheezing and all these things ni, it accounts for more than 60% of cases in the world. And it accounts as well, if you go for block exam, it accounts for most of your cases yang masuk dalam exam. So you need to know in great detail. And also, asthma is another case that it is very easy for us to ask in theory exam as well. It can come in every bit of your theory exam. Daripada MCQ, OBA, PMP, OSCE, everything. So asthma is a disease that is very, very important to know. And asthma, I can assure you, we have asked about, I've told you kita pernah tanya pasal all this aero chamber. Kan? We have asked also about pathophysiology of asthma. Pathophysiology of asthma, we can ask in PMP many times it has come up. Describe the pathophysiology of asthma. So understanding pathophysiology of asthma is very important. And also, if you understand the pathophysiology of asthma, baru you understand kenapa kita bagi ipratropium, kenapa kita bagi salbutamol, kenapa kita bagi leukotriene antagonist, kenapa kita boleh bagi mast cell stabilizer yang tak di-mention dalam you punya presentation tadi, kenapa kita boleh bagi certain drug, kenapa kita boleh bagi theophylline, bila you understand the pathophysiology, kenapa ada eosinophilia. So bila you understand the pathophysiology, so that is why you need to understand the pathophysiology. You also need to understand, you also need to remember how to classify asthma. If you have a patient came in with asthma exacerbation, you tak boleh kata diagnosis dia is bronchial asthma. That is not enough. You tak boleh kata diagnosis, your provisional diagnosis is acute exacerbation of bronchial asthma. That is not enough. An asthma diagnosis that came in with acute exacerbation, diagnosis dia kena ada first is acute exacerbation of bronchial asthma. That is not enough. You kena classify severity of exacerbation. So mild acute exacerbation of bronchial asthma, mild, moderate, severe, life-threatening acute exacerbation of bronchial asthma. Lepas tu pun tak cukup lagi. You kena mention sebab exacerbation has its trigger. There must be a trigger. The trigger can be infection. The trigger can be URTI. The trigger can be pharyngitis. The trigger can be pneumonia. The trigger can be cold weather. The trigger can be dust. The trigger can be cold water. The trigger can be anything. So, but you need to mention. So, mild, moderate, severe, life-threatening, acute exacerbation of bronchial asthma. Secondary to cold weather. Secondary to being surprised, secondary to stress, secondary to something, secondary terkejut dengan Dr. Syed dan sebagainya. So they must have a trigger, and that is not enough still. You kena sambung lagi. How do you classify the asthma? Kalau it's a newly diagnosed asthma, how do you classify? How? Intermittent or persistent. And persistent ada mild, moderate, severe. So mild, moderate, severe, life-threatening, acute exacerbation of bronchial asthma, secondary to pneumonia, infection, blah, 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 with underlying intermittent or mild, moderate, severe, persistent bronchial asthma. Kalau is asthma yang already diagnosed before, asthma yang dah ada yang dah already on corticosteroid, so how are we going to classify?
Control or
You
uncontrolled.
classify according to control. So control, partly control or poorly control. So that is a complete asthma diagnosis. And I can assure you, not knowing how to classify asthma is a failable offense. Kalau you tak boleh classify, if you cannot tell me how you classify asthma severity of asthma exacerbation, I am obliged to fail you. You deserve to fail if you don't know how to classify asthma. So you need to know. So asthma is a very, very common disease in Malaysia, in our region. So you need to know that in great detail. It accounts to most of our patients in the ward. Sebelum PKP lah, sekarang time PKP tak ada patient pun. Kan? So you need to know about that. Okay, clear? Boleh? So balik ni kena make sure semua orang baca balik asthma pathophysiology. Semua orang baca balik asthma management, tapi jangan baca Safura punya slide ni. You baca PITS protocol. Ataupun suruh Safura back key slide dia and then email back to you guys. So
Okay,
the reference should be the latest pediatric protocol, sebab at least in Malaysian hospital, if we don't get the other sources, the basic should be our Malaysian pediatric protocol, pediatric management for pediatric for Malaysian hospital. So pediatric protocol latest punya yang color ni tau, bukan yang lama punya tu. Make sure you read the latest one, dia color purple. Dia ada online pun. You can download. I can share to you. The color purple. Let me show you. Where is my susah nak buka. The color purple lah basically. Kalau nak I can email to any of you lah kalau nak. Okay, fine. Kalau you nak extra reading, please Google GINA guideline, GINA. So GINA guideline has everything. So that is the main reference point for asthma management. Okay. Alright. Any other question?
Nak tanya. Kan tadi yang dekat slide inhaler devices recommended for different age. Kalau untuk infant untuk children under 2 years old, kita guna oral corticosteroid je, tak bagi MDI. Maksudnya
What is the problem with oral corticosteroid? Kenapa kita tak nak bagi oral corticosteroid? What is the problem with oral corticosteroid? Tak dengar lah. Cap-cap suara.
boleh tulis lah.
Okay, it's okay. Problem dia macam ni. Bila you bagi oral corticosteroid, apa beza di antara you bagi oral or IV corticosteroid? Any difference tak? Presenter? Any difference? IV or oral corticosteroid?
Yes, betul.
Any difference tak between oral and IV corticosteroid?
Kalau dia punya ni lah apa ni?
So basically there's not much different in terms of onset, in terms of basically onset, distribution. It is not different. It doesn't differ in terms of onset, in terms of distribution, and in terms of pharmacokinetic. It doesn't differ much. Sama ada you bagi IV or you bagi oral. Kenapa kita bagi IV? Sebab sometimes patient tu very severe, you tak nak bagi dia oral. Bila dia oral, dia makan, dia boleh choke, dia boleh aspirate dan sebagainya. So those severe cases, kita bagi IV. Those yang milder, kita bagi oral. Tapi ideally, kita still prefer inhale steroid rather than IV or oral. Kenapa? Sebab oral or IV, it is systemic. You are giving systemic corticosteroid. And corticosteroid ada complication. What are the complications of corticosteroid? This is another favorite question. Complications of steroid. Oh, favorite question. Boleh come up in MCQ, boleh come up in PMP, boleh come up in clinical exam as well. Memang kita sure tanyalah patient yang CP on steroid dia. Memang I can assure you, you boleh tahu dah. You boleh terus jawab. Tak apalah doktor, sebelum doktor tanya saya jawab dia terus. These are the complication of steroid. Dia boleh buat macam tu dah. So I can assure you, kita will ask you what are the complication of systemic steroid. So systemic steroid ada banyak problem. Dia hypertension,
Infection.
Immunosuppression, kan? So all these things. So ada banyak head to toe complication of systemic corticosteroid. So you need to know that. So ideally kita bagi inhale steroid. Cuma sometimes because the situation tu kita bagi systemic steroid lah. So okay, does that answer your question? Okay, alright, let's proceed. Let's jump ni. Sudah. Ada berapa presentation ni?
Lagi 3.
Lagi 3, ada 4. Masya Allah. Sudah. Okay, fine. Let's go to next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Wan Muhammad Asif and today I would like to share regarding bronchiolitis. Okay, so what is the bronchiolitis? Specifically, the viral bronchiolitis is the commonest serious lower respiratory tract infection of infancy, which is less than 2 years old, but it is most common occur in infant that from 1 to 6 months old. And from the name itself, the bronchiolitis, it is an inflammation of the bronchioles, and the site of pathology is specifically to the bronchioles of the lung anatomy. So from the gross anatomy of the lung, we can see the bronchioles from this illustration. The bronchioles is more to the terminal of the airway, and the bronchioles, it is a small airway which the diameter of the bronchioles is less than 2 millimeter. So when the inflammation occurs in the small airway of the bronchiole, it tends to lead to the blockage of the airway, so can lead to the bronchiolitis, and I will explain more the pathophysiology of bronchiolitis after this. Okay, so what are the etiologies of the bronchiolitis? From the statistic in the United States, among the viruses, the most commonest virus that can cause bronchiolitis is the respiratory syncytial virus, RSV. And other than RSV, another 20% is human metapneumovirus, adenovirus, parainfluenza virus, enterovirus, influenza virus, and also rhinovirus. Please be noted that a co-infection between RSV and also human metapneumovirus can lead to more severe life-threatening of bronchiolitis. And other than virus, yes, yeah.
Can SARS-CoV-2 cause bronchiolitis?
COVID.
Can SARS-CoV-2 cause bronchiolitis?
SARS-CoV-2.
Dia ada virus yang cause COVID-19 lah. Kan nama dia SARS-CoV-2 kan?
I'm not sure.
Anyone has any suggestion? Can it cause bronchiolitis? The answer is there's no data lah. There's no evidence that it causes bronchiolitis. There's no reported cases of bronchiolitis caused by SARS-CoV-2.
Okay.
Okay, see.
And other the viruses, the bacteria also can cause the bronchiolitis, like the chlamydia pneumoniae and also streptococcus pneumoniae. But the percentage of having bacterial bronchiolitis is very uncommon. And here is only electron microscopy of the RSV. And let's see the epidemiology of the bronchiolitis. Generally, the prevalence of bronchiolitis may be higher in urban areas due to the overcrowded population and the density of population. And generally, the peak incidence of RSV bronchiolitis is in the winter months, November to March, due to the weather. But in Malaysia, the statistics show that the disease can occur throughout the year due to the weather and the cyclical periodicity with annual peaks of bronchiolitis happen in months of November, December, and January when the musim tengkujuh happen due to the weather, the cool weather. And how common the bronchiolitis can occur in infants? So by their first birthday, over 60% of children have been infected, and by 2 years of age, there are over 80%. And among the infants that are admitted to the hospital, 3% of them with bronchiolitis, and the rates of hospitalization for bronchiolitis have been rising from the statistic, and the causes can be multifactorial. Okay, so let's see the more details on the pathophysiology that can cause the bronchiolitis. So, as I mentioned before, bronchiolitis is an inflammation. So it begins with an acute infection of the epithelial cells that line the small areas of the bronchioles.
Saya cannot hear.
Hello.
Okay.
So there are four main mechanisms that can cause the bronchiolitis. So four of them is complex immunologic mechanism, the necrosis of respiratory epithelium, the action of cytokines and chemokines, and also the bronchial injury effects. So as discussed before in topic of bronchial asthma, the complex immunologic mechanism, the type 1 hypersensitivity reaction, IgE mediated, play roles in pathogenesis of bronchitis. So as we discussed before regarding the IgE mediated hypersensitivity reaction, the bound antigen and antibody of the bound antigen antibody that will bind to the mast cell that will release the histamine and also histopathology.
Hasif, sorry. I
Yes?
think there's a lot of wind in your microphone. Tak apa dengar your voice.
Oh, yeah. Hello?
Okay, that's better.
Okay. Okay, I will repeat. So the first mechanism is the complex immunologic mechanism, which is we discussed before regarding the bronchial asthma, same as this, which is the type 1 hypersensitive reaction, IgE mediated. So in this mechanism, the bound antigen antibody will bind to the mast cell that will release the histamine and also histamine-like substances that can lead to the anaphylactic reaction. So inflammation will occur in that epithelial lining of the bronchioles. Okay, just for information that infants who are breastfed with colostrum rich in IgA appear to be relatively protected from bronchiolitis. Okay, next is the necrosis of the respiratory epithelium. Okay, in this mechanism, it is one of earliest lesion in bronchiolitis, and this necrosis of respiratory epithelium occurs within 24 hours of acquisition of infection. So there are many mechanisms that happen under this pathogenesis. So first of all, there will be a proliferation of gallbladder cells that will result in excessive of mucus production, as we know that the gallbladder cells, the function is to produce mucus. But due to the infection, the gallbladder cells will be produced more. Next is the epithelial regeneration with non-ciliated cells. The infection can cause the regeneration of epithelia, but with the non-ciliated cells. So what happens when the non-ciliated cell is regenerate, and this will impair elimination of secretion of the excessive mucus and other things. And the last one is the lymphocyte infiltration. This is an inflammation, so they will be infiltrated with lymphocyte, and this infiltration of lymphocyte will lead to the submucosal edema. Next is the action of cytokines and chemokines, such as the interferon, the interleukin-4, the interleukin-8, and also the interleukin-9. These cytokines and chemokines are released by the infected epithelial cells. So the more the epithelial cells that are infected, the more the cytokines and chemokines will be released. And the action of these cytokines and chemokines will increase cellular recruitment. So from the from the from this from these three complex immunologic mechanism, the necrosis of respiratory epithelium and also cytokines and chemokines action will lead to the airway obstruction due to the epithelial and inflammatory cell debris mixed with fibrin, the mucus, the edema, and also the cellular recruitment to the infected epithelial cells. Okay, so next is there are also the bronchial injury effects which will increase more mucus secretion, the bronchial obstruction as I mentioned before, the alveolar cell dust, the mucus debris and also the more viral invasion. There will be air trapping due to the blockage. Atelectasis may happen, reduced ventilation that will lead to the ventilation perfusion mismatch, and it also can cause labored breathing due to the blockage. So here is the summary where the infected bronchioles can lead to the inflammation, the edema, and also the debris accumulation. And next, it will cause the bronchial obstruction. And finally, it will lead to the hyperinflation of the lung, increased airway resistance due to the blockage, may result to atelectasis and also VQ mismatch. So here is the illustration of the pathophysiology of the bronchiolitis, where we can see in the right illustration, the airway is blocked by the mucus build-up, the inflamed tissue, the necrosis and the lost epithelium, and also the smooth muscle tightening. Okay, so the bronchiolitis is the disease of infant. So why are infants affected most often of bronchiolitis? It is due to the small airways, the high crossing volume, and also insufficient collateral ventilation. The infant, the lung is not yet completely developed, so that's why they are prone to get the bronchiolitis, the infection of the bronchioles. Okay, so the clinical presentation of the bronchiolitis, the early presentation is the common cold symptom like the coryza, the mild cough, and also the low-grade fever. Other symptoms can be wheezing, the rapid breathing, difficulty feeding, and also that can lead to dehydration. Sign of the disease can be apnea, retraction, nasal flaring, grunting, hypoxia, and cyanosis. But please be noted that these signs is the sign of the severe and life-threatening of acute bronchiolitis due to the impair of the oxygenation to the blood. Other signs of the bronchiolitis can be hyperinflation of the lung, respiratory distress, and also fine crepitation and occasional rhonchi on auscultation. So, how to diagnose bronchiolitis?
Back. Science. Back. Okay. Back. Okay. Yang tadi. Yap. This one. Okay. Bukan yang ni. Back lagi, satu lagi. One more. Yeah, the one you mentioned about fine crepitation.
Oh, this one.
Okay, so this is the thing that you need to notice. The commonest sign in if you examine a child, the commonest respiratory sign in a child with bronchiolitis is actually fine crepitation. Problem dia adalah so many students dia assume acute bronchiolitis mesti ada rhonchi, mesti ada wheezing. That is not necessarily true lah. Rhonchi and wheezing is occasional, sometimes. The commonest presentation is actually fine crepitation. Dia ni yang nak kena remind lah. Okay, alright. Proceed.
Okay, there are few risk factors that can lead to the bronchiolitis, which is the age of infancy, which is age 1 to 2 years old. But less than 3 months, they are more prone to get to the bronchiolitis. And other than that is the premature infants, the gestational age less than 29 weeks. Also, the lower socioeconomic group in the crowded living condition that I mentioned before, parental smoking, chronic lung disease, severe congenital neurologic disease, hemodynamically significant congenital heart disease, and also airway anomalies. Okay, so what are investigations that can be done in acute bronchiolitis? Okay, in bronchiolitis, investigation is not really necessary, but for okay, so when the patient came to the hospital, we need to check the pulse oximetry because we need to check the oxygen level of the child because we need to suspect the hypoxia. And also, if the diagnosis of RSV of bronchiolitis can be confirmed by the nasopharyngeal aspirate and also the viral immunofluorescence or PCR for infection control purposes. Okay, what about the chest radiography, the chest X-ray? Is it necessary to be done in acute bronchiolitis? It is not necessary, but it is recommended for children with severe respiratory distress, unusual clinical features, and underlying cardiac or chronic respiratory disorder, and if intensive care unit is required. And other investigation are not necessary, but can be done to rule out other differential diagnosis like the bacterial infection and also pneumonia. Okay, here is the chest X-ray of the bronchiolitis, and here is the severe one where there is atelectasis of happen in this child. Okay, let's proceed to the management and the treatment of the acute bronchiolitis. There are several indications that we need to be done for the hospital admission. First of all, the absolute indication, if the child having the cyanosis and marked lethargy that leading to poor feeding, any respiratory distress, apnea episodes, and also diagnostic uncertainty. I will show more in the table after this. The relative indication, if the child having the congenital heart disease, premature child, any pre-existing lung disease or immunodeficiency, Down syndrome, and also social factors. Okay, here is the guideline for hospital admission in viral bronchiolitis. So we can see that for hospital management for bronchiolitis, if the child is aged less than 3 months, we need to manage in the hospital. And if the child having the toxic looking, and also if the chest irritation is severe. And also, like I mentioned before, we need to check the pulse oximetry and regarding the risk group. Okay, here is like before. Okay, so here is the indication that intensive care unit is needed, where the failure to maintain saturation more than 0.92 with increasing oxygen requirement, and also if the respiratory status is deteriorated and also impeding exhaustion. And if the apnea episode is worsened, we need to immediately admit it to the intensive care unit. So basically the treatment can be under these 6 categories, which are the oxygen therapy, the nutrition and fluid therapy, the nebulous bronchodilators, corticosteroid therapy, ribavirin therapy, and also antibiotic therapy. But please be noted that the acute bronchiolitis is self-limited disease due to the viral bronchiolitis. But here is the empirical studies that we need to do as for the treatment of the bronchiolitis. So first of all, the oxygen therapy. We know that there are blockage in the bronchioles of the child with bronchiolitis. So we need to give the oxygen therapy. Okay, the treatment, that supportive treatment of oxygen therapy is maintained above 93% of the SpO2. Next is the nutrition and fluid therapy. Due to the condition of the bronchiolitis, the children frequently have poor feeding and at risk of aspiration, and this can lead to the dehydration. So it is recommended to give nasal gastric tube if the children who refuse to feed. And what about the fluid? Intravenous fluid are given if the child having the severe respiratory distress, cyanosis, or apnea. Next is the nebulous bronchodilators. There is no definitive evidence to support the routine of bronchodilators, but based on the empirical studies, the efficacy of beta-2 agonists, which is the salbutamol, in treatment of viral bronchiolitis remain inconclusive. Based on and the modest clinical improvement of nebulous beta-2 agonists given in oxygen can be given. Next is the corticosteroid therapy. It is also not necessary to be given to the patient, but based on the meta-analysis of the use of systemic corticosteroid show possible benefits in infants with severe bronchiolitis that will result in reduction in clinical scores of bronchiolitis and length of hospital stay. There is one antiviral agent that that are approved for RSV bronchiolitis, which is the ribavirin. What about antibiotic? Antibiotic is not recommended as the viral bronchiolitis is caused by the virus, but it is recommended if the infants having the recurrent apnea and also circulatory impairment, the possibility of septicemia, acute clinical deterioration, high white cell count, progressive infiltrative changes on chest radiography, because we need to give prophylaxis for other diagnosis. Okay. Thank
No,
you.
we don't give antibiotic as prophylaxis lah. Back. So we don't give as antibiotic. We don't give as prophylaxis lah untuk.
Okay.
So it's just that sometimes if there is progressive infiltrative changes, you could actually be facing with pneumonia rather than bronchiolitis. So that is the reason why you cover with antibiotic. Okay, and then so generally antibiotic is not needed for bronchiolitis because majority is viral. Very few is caused by bacteria. So generally you don't need to give antibiotic. Back, one more slide. Back. Okay, ribavirin is not easily available. Most centers do not have ribavirin. Corticosteroid, systemic corticosteroid, it doesn't really benefit much. We don't give, no one gives corticosteroid. Back. I want to ask about nebulization. Okay, is this all the nebulization that you can give? So this is the problem when you present something for Malaysian punya management, but you don't refer to Malaysian punya pediatric protocol. When you don't refer to Malaysian punya guideline. Okay, so what are the nebulization that you can give other than bronchodilator? Anyone has any suggestion?
Normal saline.
Saline, yes, you can give saline. Anything else? So, okay, macam ni. For bronchiolitis, you can either give nebulized bronchodilator, salbutamol, or you can give nebulized normal saline, 0.9% saline, or you can give nebulized hypertonic saline, which is 3% saline, or you can give also nebulized steroid. So nebulized steroid ini is still in study lah, but I think more studies are now suggesting that it is beneficial. So you can give 4 types of nebulization. Okay, why? So the issue macam ni, you need to understand. So acute bronchiolitis and asthma, post-viral wheeze, multi-trigger wheeze, episodic wheeze, all this cause similar symptom of wheezing triggered by most likely viral infection. What's the difference in terms of pathophysiology di antara asthma dengan acute bronchiolitis? So asthma mainly it is type 1 hypersensitivity. Mainly is bronchospasm. That is the main problem in asthma. That is the main problem in asthma. In acute bronchiolitis, so you mentioned several pathophysiology, but the main pathophysiology is airway obstruction caused by secretion. So that is the caused by inflammation. So bronchiolitis, so inflammation of the bronchiole. So your bronchiolar wall thickening. Bronchiole to wall there become thickened. So bronchiolar thickening and also caused by mucus secretion. So all this is the one that causes obstruction, airway obstruction. So airway obstruction produces the turbulence flow in the airway. So turbulence flow in the airway causes apa? Causes wheezing. So you boleh dengar wheezing, you boleh dengar rongkai dan sebagainya because of the mucus and also because of the bronchiolar thickening. Okay, mucus menyebabkan you can hear this fine crepitation. Okay, so bila you understand pathophysio, asthma it is bronchospasm. Bronchiolitis mainly is mucus and also airway thickening. So in this sense, asthma memang first line kita bagi beta-2 agonist. Sebab apa bagi beta-2 agonist? Sebab beta-2 agonist causes bronchodilation, smooth muscle dilatation, kan? So this is the effect of salbutamol. Sebab pathophysio asthma is mainly bronchospasm. Tapi in acute bronchiolitis, mainly majority of them it is just mucus and also thickening of the airway. So in this sense, kalau you bagi bronchodilator dalam keadaan there's no bronchospasm, will it show any effect? Not really, kan? Tapi kalau you bagi, for example, you bagi isotonic punya solution macam normal saline, you bagi nebulized normal saline, what will happen? Your mucus will become more diluted. Jadi more diluted, more loose. So loosen up your mucus. So mucus pun senang nak pass through. You boleh keluarkan. Dia senang nak absorb into the lymphatics. So it clears up the mucus. Sebab you loosen up the mucus. And also some studies have shown if you give hypertonic saline, 3% saline. So normal saline is 0.9%. Hypertonic saline is 3%. If you give 3% saline, it is suggested that with 3% saline, dia more reduction in terms of the mucus. Macam mana dia reduce? So you know hypertonic saline by osmosis. Bila you bagi hypertonic saline, osmosis, what happen? It will absorb the fluid from the airway, kan? From the airway absorb into the, masuk dekat wall lah, masuk dekat lumen, kan? So it reduces the mucus as well. So reduces the obstruction. So there is a role for hypertonic saline. So there are some studies suggesting hypertonic saline itself can cause irritation and some more bronchospasm. So the last nebulization you can give is actually nebulized steroid as well, because you know steroid it affects at cellular level, at molecular level, at tissue level, it affects at organ level. So it affects with your immunoglobulin and things. So steroid the effect macam-macam. So generally steroid can also be useful lah. Okay. So how do you treat? So usually the first line is you bagi saline. So kalau macam banyak you rasa banyak wheezing, so you can give nebulized bronchodilator. You bagi sekali, kan? Kalau patient tu banyak rongkai, you bagi sekali nebulized salbutamol, and then you check balik ada improvement ke tak. Sebab kalau the pathophysio in that particular child is mucus and airway thickening, bila you bagi bronchodilator tak ada efek lah, sebab ni there's no bronchospasm, kan? So obviously dia punya wheezing, dia punya rongkai takkan improve. So bila you bagi bronchodilator, you reassess again the patient, you auscultate the patient again. If there's not much changes, then stop, tak payah bagi lagi dah, sebab there's no effect. The pathophysio in that patient is not bronchospasm. So in this sort of patient, if needed, you can give nebulized saline, nebulized hypertonic saline, or you can consider giving nebulized corticosteroid. Faham? Clear? The mainstay of treatment in acute bronchiolitis is hydration and oxygenation. This is the mainstay. Acute bronchiolitis, the most important management is oxygenation and hydration.
Hydration.
Okay, clear. Okay, let's proceed with the next. Oh, any question? Any question?
Doctor,
Hmm.
about the thickening of the bronchiolar wall, will it
Yep.
resolve by its own, or is there any treatment to resolve it?
So the thickening, why is the thickening? It is because of inflammatory processes, kan? Inflammatory processes, cytokine, chemokines, and all these things. These are inflammatory reaction. This is the one causing necrotizing and apa semua benda. It's because of inflammatory reaction. So this is among the reason why kita boleh bagi steroid. Sebab steroid reduces inflammation, kan? So sebab itu kita bagi. Sebab tu we can give a systemic steroid lah, but again systemic steroid ada complication dia, kan? You bagi systemic steroid and then you stop. Stopping abruptly systemic steroid pun ada complication dia, kan? Dia kan? I hope you know lah kan, benda macam ni kan, dia boleh masuk exam ni benda ni soalan tu, kan? So we've had that patient yang ada problem bila dia stop steroid abruptly, dia ada complication dia. I'm not gonna talk about that lah, I hope you know lah. Okay, so kita ideally kita tak nak bagi systemic steroid, tapi kita boleh bagi nebulized steroid, kan? Sebab steroid reduces inflammation, and you know inflammation dia bukan forever inflammation ni. Inflammation dia akan improve with the patient's condition, and so that's that.
So doctor, in moderate case, will we guna steroid juga in that case?
Okay, steroid usage for acute bronchiolitis ni, guideline ni tak ada lagi. We don't actually have the proper guideline, so we don't use it regularly. Tapi we are using it more now. So sometimes if the child came in with moderate and severe cases, we do give regular nebulized steroid. But we don't use it regularly sebab the guideline, this is very new. I think the last year dia baru kita promote usage of nebulized steroid.
Maksudnya the only treatment is nebulized saline and also oxygenation.
The only treatment is hydration and oxygenation. That is the main treatment. But you can consider nebulized saline. So that is the other thing, because nebulized saline, hypertonic saline or isotonic saline, it reduces mucus and reduces thickening of the airway. And then you can consider nebulized bronchodilator kalau dia responsive to bronchodilator. Sebab apa? Sometimes you tak tahu. Certain patient dia ada element of bronchospasm. That's one thing. Second juga, this first bronchiolitis ni yang jadi masa budak ni less than 2 years old, you're not sure, is this the first presentation of a post-viral wheeze? Or is this the first presentation of an episodic wheeze? Or is this the first presentation of bronchial asthma? You don't know. So bronchial asthma is a bronchospasm. So that is why we give bronchodilator. Kita tengok macam mana dia respon ke tak. Kalau dia respon, kita continue to give. Kalau dia tak respon, kita tak bagilah. Sometimes kita boleh alternatekan dan sebagainya. But the main thing is, when you start any treatment, you must use your brain. Don't just depend on the guideline and SOP. You need to use your brain. So that is why understanding pathophysiology is very, very important. If you don't understand pathophysiology, macam mana you nak decide? You nak start apa? You akan guna guideline macam baik jadi clerk je kan? Baik jadi clerk je. So as clinician, kita kena ada clinical judgement, kena ada clinical acumen. So for that, kita kena guna kita punya brain. So that's why, that's the thing. So understanding pathophysiology is very, very important. Okay, alright. Karena pukul 10:45. Do you want to continue ke nak kita nak reschedule untuk 2 lagi?
Doktor busy ke?
I cannot. Alright, so I think let's reschedule the other 2 presentation. Kalau boleh weekend lah, Sabtu atau Ahad. Cuma Sabtu tu morning atau malam sahaja.
Alright.
Sunday tu whole day boleh lah. Tapi Sabtu pagi saja. Tengah hari tak boleh. Tengah hari I have something. And then macam tu lah. So tell me when and inform Siti Naya as well. I think let's end the session with tasbih kafaran surat.
Thank you, Doctor.
Can I have presenters to email me your slides?
Okay, dah.
Okay.
Alright.
Alright. Okay, thanks. Okay, Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.